Please welcome to the stage Dr. Jonathan Perlin, President and CEO of the Joint Commission.
Well, good afternoon. It is such a privilege to be here with individuals who have dedicated their professional careers to quality. What a thrill, and great thanks to each and every one of you, and great thanks to all of our colleagues across CMS and government. Well, I want to talk about a new era for the Joint Commission, and the thesis of my talk is all about trust. Outside of family, there is no more intimate relationship than a patient with healthcare, and that relationship is really predicated on trust. Because in healthcare, trust is everything. Trust that every instrument, every dose, every detail has been checked, measured, and carefully prepared. That every doctor, nurse, and team member have what they need to give every patient safe, high quality, and compassionate care. And it's really on the basis of supporting trust that we're introducing a new era in accreditation. Our goal is not simply to reduce burden, though that is an effect of our new approach, but it's really to support the enhancement of trust in the safety, in the quality, in the compassion of healthcare, because of our shared responsibility to really give patients the best possible chance for optimal health and the best outcome. And we do that because we have really a new team, a team with extensive clinical and operational experience. I want to give you a sense of this team because all of us have been on the other side of surveys, and we're bringing the learnings of being on the other side of survey to really helping to drive the value of accreditation as well as certification in the improvement of care. So starting at the left, our newest addition to our team is Marlena Davis. She was the Deputy General Counsel at the Cleveland Clinic. She understands healthcare and healthcare operations. Neelam Dhingra founded the Patient Safety Unit at the World Health Organization after To Err is Human. Ken Grubbs was my colleague at HCA Healthcare. He was in charge of regulatory compliance for 2,200 sites of care. He understands scale. Importantly, he's a doctor of nursing practice, our chief nursing officer, and a former National Patient Safety Foundation fellow. If you don't know Jim Merlino, you should read his book, Service Fanatics. He's a colorectal surgeon by background. He's our chief innovation officer. You'll understand if you read his book why he is so intensely passionate about patient safety and patient experience. It's because of a tragedy in his own family that he recounts in that book. And I'll let you have a look at that book to really understand what drives him. It's not dissimilar than what drives our new Chief Medical Officer, Liz Mort. Liz worked with Lucian Leap and others at Mass General. Liz is really extraordinary. She was the Chief Quality Officer there, and she worked with tens and thousands of colleagues in advancing quality and safety. Sure, many of you know Dana Safran. She's dual-headed. She is not only the CEO of the National Quality Forum, but she is also our Chief Scientific Officer. We're delighted to have Navy veteran, nurse, and attorney, Catherine Spades, who leads our public policy and government relations and brings a nurse's heart to her work in that role. And the other new member of our team is William Walders, who, before he came to be part of our team, ran the entire IT system for the military health system. Extraordinary background and responsibility, and all of these individuals are partnered together because they could be anywhere, but they choose, like you, to make a difference in the quality of care. Well, we thought it was time for a transformation because the last fundamental transformation of our accreditation process was at the time of the inception of the Medicare program, as you heard Dr. Oz say, 60 years ago. Now, you've heard as a theme today, data innovation and data availability. And we are sitting on 60 years of comparative performance data. And with the advent of AI, we have the opportunity to better support healthcare organizations, clinicians, policymakers in understanding how to come to the best decisions, what works best, and frankly, what doesn't work. And in that process, streamline, simplify, better support, and more efficiently share, importantly, best practices. This is the reason we're calling it Accreditation 360, because we're not only looking at what doesn't work and needs improvement, But we want to learn from what does work and make that a standard. Now, because all of us came recently from operational backgrounds, we appreciate that there has never been a more complex time in healthcare. Whether it's clinically, operationally, financially, or otherwise, there are intense headwinds, things like workforce challenges, et cetera. But our responsibility is unwavering. We need to assure, as I said at the beginning, that people have reasons to find trust in healthcare because they can count on safety and effectiveness and compassion. Well, let me give you an outline of some of the changes over time. First, we rewrote the standards manual, and I'll show you what that looks like in terms of making it simpler and easier to follow. We retired a number of standards that we found to be obsolete. We've made enhancements to the survey report so that things that may be significant aren't conflated with things that are in a state of improvement. We've gone from cryptic codes to natural language labels, and we now offer the performance benchmarking tools based on those data that are available, and an optional continuous engagement model so that a survey isn't an unusual event, but readiness is a continuous event. And the Surveyor Excellence Program, because we want our team to be composed of those individuals who are really top of game and also compassionate in the same way that you would expect compassion from your caregivers. Well, I tried to come up with a graphic using AI to show how we've rewritten the manual. And while it's not quite unscrambling the egg, it's kind of putting the spaghetti back in the box. And if you look at the old manual, you will find that those standards that came from CMS or FDA or other authorities, as well as Joint Commission, are now separated into clear standards. Well, associated with this, and I know it's going to break hearts everywhere, a reduction in requirements from 1,551 to 774. Tears of sadness, I assume. Well, the math is 777 there. You're probably thinking, what is that number? And we've also made the language much more accessible. This is actually the forthcoming standards manual standard on verbal orders. Let's just make it simple and easy for people to follow so the focus is on reliability and safety. And if you say, well, I'm worried, you got rid of a lot of standards, you're reducing rigor, still a little thought experiment. What is more rigorous? Walking for 30 minutes or running a 4-minute mile? It's not a question of quantity, it's a question of focus. It's a question of value behind that focus. And we want to help organizations focus on what's important. As Chris Klomp said earlier today, if everything matters, nothing matters. What we really want to drive focus on are the things that matter most. And those things are things that working with clinicians and healthcare organizations and purchasers and payers, and most importantly, consumers and patients tell us what matters. Let me show you what it looks like in terms of how we've synthesized. Well, of course, there are always the conditions of participation, but on top of that, Joint Commission added what we call above and beyond standards, the most important of which we refer to as national patient safety goals. Well, that collapse of standards now goes into a group of 14 different topical areas that we call national performance goals. And in that process, 200 non-regulatory requirements became these 14 performance goal areas. And what was the lens we took to reducing regulatory burden? We asked, are the requirements redundant? Let me give you an example. This was part of the ongoing reduction in unnecessary requirements. But if you look at tobacco use in hospital, it was under environment of care, it was under life safety. There were even implications in terms of leadership. Well, smoking in hospitals is not allowed anyway, so why add that to the burden? And why have 3 teams that you assign to environment of care or life safety focused in different ways, perhaps taking different approaches because the language was dissimilar? That leads to number 2, difficult to score. Things that weren't ever scored probably weren't working as a standard or weren't an issue. Or where there was weak evidence, or where frankly the juice just wasn't worth the squeeze. And in that process, we came to those areas that I think all would agree are the most critical. And I want that to be very clear to you in terms of what those areas are. So I'm going to walk through them for the first time. that the right patient gets the right care, ideally at the right moment. The importance of being able to track critical results. The importance of 2 patient identifiers to know that it is, in fact, the right patient. Patient flow in hospitals, handoff communication, procedural verification. Just this past week, a friend of mine who's a journalist wrote to me and said, I had hand surgery, my finger was signed. Did you guys have something to do with that? And the answer is, yes, we did. Because for too long, there were terrible reports of wrong site surgery. Now, I wish I could tell you that doesn't exist anymore, but it's rare that the wrong kidney gets taken out, the good one taken out, when the other cancerous kidney is left behind. It's rare, but it happens that there's a wrong joint procedure. It's still too frequent that the wrong eye receives a cataract or lens. But I want to commend our colleagues at VA for their procedural safety activity. It won the Eisenberg Award because by putting these processes into place to having a robust timeout, they've demonstrated with data that it makes a difference in terms of safety. Emergency management. I wish the world were different, but it speaks for itself that we can have cyber attacks or grid outages, et cetera. And being able to operate in a digital world when it goes dark is an absolute requisite to safety. Pain management speaks for itself. Dr. Oz spoke about vulnerable populations. He spoke about rural populations. And when I was undersecretary running VA, I understood the difference. I learned the difference between rural and frontier. Excellent health outcomes for all. A culture of safety. You don't want me using a technology because I have a financial interest in it. That's tremendously important. And one of the areas I want to focus on is workplace violence. When I trained, there was a patient bill of rights. Today, we need a bill of responsibilities that assures physical and psychological safety for patients, staff, visitors alike. And we want to provide the air cover for organizations to assure that they can take the measures necessary to create that physical and psychological safety. You know, we're sad to mourn the loss of Lucian Leap. But I remember a discussion with him. He asked me, John, if you could do one thing in your career to improve safety, what would it be and why? I said it would be hand hygiene. We could make greater gains in safety through that one act alone, and I do not understand why the hand hygiene on a cruise ship going through the buffet line is better than most of healthcare. And so this is obviously a critical opportunity. In terms of patient rights, effective communication, informed consent, and one that I want to tell you a story about. A colleague had an unfortunate run-in with a door. And she went to seek health care at her own hospital. And as she was getting examined, because she had a nice shiner, one of the nurses took her quietly aside, brought her back and said, I just want to make sure that you have a safe place to go home to. Do you? And she came back and told me about this experience. She is in a very loving relationship, et cetera. She said, I didn't know how useful that could be because I just imagined myself in the position of someone who's abused. And I was so proud of the fact that we had a hand in that. And I think that's absolutely extraordinary to be able to make that sort of difference. And we're now really quantifying the value of the differences we can make. Suicide risk reduction, screening. Those with chronic illness are far higher propensity to suicide. Bidirectional tracing of tissue for transplants, following manufacturers' instructions for use. That one actually traces its provenance to FDA that requires that, traces its provenance to the conditions of participation. We want to make sure that materials are used as they should be. I mentioned workplace safety, but managing security risks. Unfortunately, we read occasionally about things like baby abductions from a newborn intensive care unit or a nursery. And we need to make sure that security measures are in place and staffing. We need to think about how we staff and how we staff differently in an era of technology when our human skills are augmented by technologies. In imaging, anybody here ever seen what happens when a magnetic object gets lifted off the ground by an MRI? Yes, not pretty. I have. I saw what happened when a small oxygen tank got lifted off the ground. I wasn't there for the event. I saw it afterwards. it turned into a rocket. I don't mean this metaphorically. I mean when that tank lifted off the ground in the magnetic field of the MRI, it actually slammed into the MRI, breaking the valve at the end, turning it around as a rocket, sending it through a cinder block wall, through the next room, through the next cinder block wall, until it stopped at the leaded wall of the CT suite and PET scan. What other sorts of imaging safety? Well, till now, we haven't checked the cumulative dose of radiation for children. It's your child. Wouldn't you want that cumulative dose of radiation known? Those are the sorts of things. Medication management and antimicrobial stewardship speak for themselves. And so we want to provide not only what the opportunities are, but ways to correct them and ways to really make best practices more universal. And so to complement the SAFER matrix, which looks at the magnitude of risk with how widespread it is, we're introducing the SAFEST report, which is going to be a national survey of leading practices in healthcare. Put that into a database. And for those requirements for improvement that are most frequent, want to have a video library at the top 50 so that we can have a nation of collaborative learning. Some of this is not rocket science, though. One of my colleagues took this picture. I would personally have to decode all of these acronyms for different standards. Isn't it better just to put it in natural language? Well, that's what we're doing. Wouldn't it be better to provide benchmarking tools so that you can have in real time an understanding of how does the performance compare at my 0 to 99 bed hospital in an urban environment, safety net, et cetera? Choose your own cohort. So a prioritized list of items, benchmarking by peer group. If you're a multi-facility organization, so you can benchmark across the different units, or benchmarked by domain, leadership, national performance goals, infection prevention, and the like. And have a set of materials that you can have discussions with staff and governance alike, because it's not just an embarrassment, it's an opportunity for learning, and in terms of the leading practices, an opportunity for pride. And so we understand the importance of reducing regulatory burden. We understand the fear of the triennial survey. And we also appreciate that there's been a lack of transparency. So starting this month, we will post all of the standards online so they're publicly available and searchable. Now, I am a data junkie. I'm a tech junkie. I had the privilege of leading the implementation of the graphical electronic health record across VA, worked with meaningful use, and I love tech. And when I came to Joint Commission, I thought a lot of the stuff we could just do with data. I want to tell you a story about being an observer on a survey. What did I learn? Paraphrasing the great philosopher Yogi Berra, you can see a lot just by watching. Let me tell you what I saw. Imagine a 300-bed hospital, part of a system that, let's say it's between 20 and 80 beds, in a first-tier or second-tier American city, place that you would likely go with comfort. When we walked to the OR, we saw an autoclave between two of the different operating suites. And the infection control nurse asked, what do you use that for? Well, we flash instruments. And she said, that must be a rare occurrence. I said, no, the doctors like it. We do it for every instrument. How do you program it? Oh, we use these instructions. And in one of those plastic binders that says, downloaded from Google for illustrative purposes only, not to be used for programming. Serrated instruments, you want those scrubbed. The number one RFI is really high-level disinfection, requirement for improvement. Walked into the pharmacy, and on the left side in the sterile pharmacy, they were compounding entirely by the book. On the right side, the tech was actually making a solution for what's called intrathecal injection into the spinal canal up to the brain to deliver. And she was pipetting in and out of the hood. Well, you may as well be making it on your kitchen counter if you weren't under the hood. There was a systematic issue with infection control. Now, the hospital said, well, we haven't had any problems. That's what they said in Tennessee. Those of you who remember the compounding pharmacy debacle with the steroids, is that you didn't have the numbers that showed there was a failure until there was a failure. But this was really bad process. And so it's both data and observation that are so incredibly important. So let's turn the page to Certification 2.0 and talk about a transformation to truly data-driven measurement of performance. Well, just to be sure, our notion of certification is an assessment of programs, not necessarily institutions, for excellence. In the past, that's been an observational activity. Imagine a world where instead of having a bunch of similarly intended measures, say, for example, for ACE inhibitors for heart failure patients, which you know reduces the chance of rehospitalization, emergency department presentations, most importantly for the patient, gives better function. Instead of having 13 competing similarly intended measures, imagine getting commercial payers together and saying, this is the one we agree on. Well, let's talk about that in a little bit more detail and how that might apply actually across the continuum of care. Well, let's look at this ecosystem of more advanced, lower burden, higher performance measurement. Let's start with the patient, because we should always start with the patient. So that patient with heart failure, we'll call him Lewis L., composite of many of the patients I've cared for, has heart failure. What would happen if we had one measure instead of 13 competing measures? Better chance of that patient getting the intended therapy. Purchasers would be informed by knowing where the highest likelihood is. And payers actually could gain traction by working with other payers, and instead of having moderate performance on their own measure, have excellent performance on a measure that's conserved across the entire healthcare ecosystem. And if you're a clinician or a healthcare organization, you don't have to code 13 similarly intended measures. You don't have to be in a world of competing formularies. And remember, is this the insurer A measure, the insurer B measure, or insurer B product A measure? This is the measure for an ACE inhibitor in heart failure. And if you do those things, payers then might reward with preferred network placement or even relief from some of the regulatory burden. You heard about the burden of prior authorization earlier today. And most importantly, when you take it back to the patient, the best possible clinical outcome. Well, this isn't a pipe dream. This is what we're doing now. This is next generation certification. And we're doing this collaboratively through the National Quality Forum, our affiliate, to bring patients, consumers, purchasers, payers, clinicians, and healthcare organizations to the table. We're starting in 4 very high importance areas. And you heard earlier about the importance of maternity care, so we use that as a bit of example. But as we get to that, I want to show you what the accreditation and certification stacks look like. So today, if you have an accreditation survey, and it's July 1st, you might have your advanced stroke certification in September, and you might have your bariatric or maternity in December, and on it goes. What if the certification were data-driven instead? And what if you could actually earn your way out of inspection by really high performance on outcomes? Isn't that what we care about as clinicians, as patients, getting the best possible outcome? And so what we see is an evidence-based, data-driven, and outcomes-oriented measure sets with less inspection for high performance and a much lower burden for all of the healthcare organizations and clinicians who are so incredibly busy today. So what would the notional set look like? Well, it'll be very outcomes-focused, maybe a few process measures that are really tight. Anybody here drive today? Did you wear a seatbelt? Process measure. Why'd you do that? Because it's so tightly linked with the outcome. So a tight set, parsimonious, balanced across patient-reported outcomes, patient experiences, priority care processes where necessary, and biometric data. And measures that are validated and have been arrived at by consensus, National Quality Forum process, where there's a low burden. And I'm going to come back to that in a moment. Ideally automated as much as possible so that we can fill out the priority sets. Well, let's go from the abstract to an actual example. And if you look in the sort of right-hand mid-level, you see that there's, we envision a world where we can track across pre-hospital, hospital, and post-hospital, because our health, our care, our treatment doesn't start and stop at the doors of entry and exit of the hospital. It's a continuum. And we need to be thinking about that continuum henceforth. And you can see in each of these areas that there are measures, for example, patient-reported outcomes, depression, anxiety. If you look at the clinical and biometric, postpartum hypertension, you can see newborn complications, severe obstetrical complications, and priority areas. And this is a critical one, is the timely treatment of preeclampsia and eclampsia, the hypertension of pregnancy. And you get a balanced set, a parsimonious, tight set of things that all of us would agree are the outcomes of interest, because we have, as Dr. Oz said earlier, the worst possible maternal health rates in upper income countries. And in terms of low burden, many of these measures, particularly in this set, are already validated and already in use. So putting it together is really not that difficult for the initial measure set. The other areas where there is more difficulty, and we'll have to develop those measures, but you can see the fact that these are in use make it an easier bar to cross. But I'm a clinician, and when I'm taking care of that heart failure patient, I love taking care of patients. And the reason I went into administration is because everything I love about individual patient care, you could pull a lever and do at a global level. And that's really cool. But one of the things I don't love is taking care of a patient as an act and then having to not only chart, but record data for a quality measure as a separate act. How do we make those measures a transparent byproduct of the care that we deliver? Well, this is the notion about clinical sourcing of data, ideally through the electronic health record. We're really excited about the use of artificial intelligence in terms of being able to abstract in a more automated fashion. You probably heard about some of our AI partnerships that will do that. That there's a cycle that aligns value throughout the ecosystem that drives the best possible outcomes for the patients that all of us are privileged to serve. Now, there's one more thing that I want to mention before I stop, and that is we live in an era where there is a technology that is likely the defining technology of the century. It is the technology that offers what in economic terms is called a step change in performance. Step change really means a discontinuous improvement in productivity, quality, safety with the same or fewer input of resources. We have the step change opportunity. And so we announced a partnership with the Coalition for Health AI. You saw Brian Anderson on stage in discussion with Dr. Oz. They're convening all of the ecosystem around AI to agree on technical standards, to agree on descriptions of AI models. And they will do their certification in that arena. We look, on the other hand, about the application of technology in the healthcare environment. And this extends directly from our responsible use of health data and building from the health evolution trust framework where experts, privacy experts, and patient representatives and technologists and others came together. They said, well, what is it that we need to have? We need to assure privacy. We need to assure security. We need to assure limits on use. We need to assure transparency and self-governance. And what does self-governance at a medical center or application site of an AI technology look like? Well, it looks like the same set of responsibilities as the appropriate use of an MRI. But let's dive a little deeper into what that means specifically for an AI tool. Well, many of you are quite aware, I'm sure, of an AI, of an algorithm that went awry. It was meant to improve performance for heart failure. Unfortunately, it did just the opposite because it amplified some of the problems with heart failure care. And so that self-governance process would have three components. One, assuring that the math in the algorithm is right. Are you getting the right answers? Assuring that the clinical recommendations are right. Is it really embrace heart failure in terms of the best knowledge of the time? And is the applicability of the algorithm correct, that you're not using an algorithm developed in adults for the care of children as an example? And so we're really excited about supporting the use of an innovation with technology. And we're excited about doing this because it's really an element of trust. So when is the official launch of all of this? You are here for the official launch. What are our goals? Transparency, reduced burden, and improved healthcare because it's a basis of trust. And remember, in healthcare, trust is everything. Trust doesn't just happen, it's earned by setting the bar high, by following the proven evidence-based practices, and delivering high quality, the safest, and most compassionate care each and every day. And I know that's why you're here. That's why I'm here. Thank you all very much for everything that you do. Thanks to all the CMS colleagues. Thanks to all of our federal colleagues in particular. It being July 4th this week and being the former leader of the VA. Special thanks to our veterans and service members, and thank you all for your commitment to quality and service.
Please welcome to the stage Dr. Dora Hughes, CMS Chief Medical Officer and Director of the Center for Clinical Standards and Quality. Dr. Shari Ling, Deputy Chief Medical Officer for CMS and Center for Clinical Standards. And Quality Deputy Directors Tamira Garcia and Will Harris.
We got space, guys.
Let's do it. Spread it out.
Spreading, he was talking about infection control, I feel like, what an incredible first day of QualCon. Thank you so much again for all of you who are participating. What a perfect way to close out. Dr. Perlin's remarks resonated with me on so many different levels. Perhaps he ended on trust. Certainly I agree. Perhaps that's the most important. But I'm also still thinking about how can we as CMS move from complexity to clarity in all that we do. We also today we thought we'd do the briefest of recap. We promise it will be brief. We started this morning with Dr. Oz, of course, and we were able to hear his vision, his thoughts, how he's going to double down on reducing burden, interoperability, technology, all of that. Then we had a great panel with the CCSQ Center Directors. I've heard a lot of informal feedback on how grateful people were to be able to hear directly from the center directors their priorities. I also heard a couple of people say, wow, I can't believe they've only been here for 6 months and already they certainly have hit the ground running and accomplished so much. Then we were able to hear from Dr. Volp, how small changes can have an outsized impact, and particularly in the areas of prevention and health. As well as a deep dive on food as medicine, and I appreciated his practicality in terms of what can CMS do, what can payers do, what can everyday organizations in the community setting, what they can do. We also learned a few terms that I have to look back up. I think one was maybe bounded rationality, or so there was lots for us to reflect on there, and so it's always wonderful when we could learn a lot. So I thought, true for many of us, that it would be hard to choose between all the sessions and the various tracks. And so we divvied up the themes, we divvied up the tracks, and I gave my colleagues the impossible task of doing a recap, providing a highlight, one thing that they took away from the session, deferred to them on how they will spend their 2 minutes each. And so first, we're going to start with Dr. Shari Ling, Deputy Chief Medical Officer at CCSQ.
Excellent. So my challenge was to sum up the lessons learned, what excites us about prevention. I do want to dial back to a comment that Chris made earlier. He said, prevention doesn't have a chance. But he then went on to, along with Abe, focus on goals of care. So if we focus on patient goals, what each and every person needs, that's important context that frames the opportunities to advise what can work for prevention, what will be not only evidence-based, but person-appropriate, person-centered. So I think that is an important take-home message for all of us. In our CDC session, we then learned about the latest evidence that is emerging that will give us clarity on how, for whom, and when preventive measures, actually including lifestyle, can be very effective. And The evidence is emerging. There's incredible variability across the country. However, what is common to all across the country is the more people are engaged in their own care and in their communities, the better the outcomes are. The third lesson was a important reminder to me as a geriatrician in the session that was dedicated to nourishing people living in, receiving care in long-term care settings. That it is not just about food and hydration, it's about nourishment, it's about care, it's about compassion. And all of that is necessary in order for us to optimize health outcomes, and prevention still matters, even at the end of life, even in the long-term care setting. And the final point I want to make is that in our generational listening session that our team led, we really started to scratch the surface for understanding all the factors that might impede preventive care and all the opportunities, some technical fixes, some cool toys that could actually help us as clinicians, as patients, as beneficiaries, as health systems. And with that, kick it to Tamira for the technology.
Tamira Garcia, also Deputy Director at CCSQ.
Thank you so much today, folks. And I'm going to use my handy dandy digital tool to talk to you all about the driving innovation through technology and data track, which I thought was extremely important today. So I am a firm believer that speaking something definitely adds to our ability to memorize it and to push it into action. So I am dedicated to an interactive recap today and would like to engage in you all, if you humor me, with a call and response activity on the 3 points that I'd like us to take home today. So the first, I'm gonna say it and I ask you all to repeat it back to me. Digital transformation is essential, not optional.
Digital transformation is essential, not optional.
Thank you. So with the dedication of everyone in this room, our public-private partnerships, we are looking forward to a world where patients have access to data in real time, where they can actually begin to advocate and participate in their healthcare. We're also interested in digital technologies, including but not limited to AI, that will enable clinicians to reach more people without replacing them, things to reduce burden as they leverage data for decision making. And these advancements are extremely important, foundational even, to addressing issues that Sue talked about, like care coordination and bidirectional communication between patients and providers. So that's the first of the 3. We're gonna go to number 2 now, right? The next one is, we are going to work together. This is a 2-parter. We are going to work together.
We are going to work together
To build a patient-centered, interoperable digital ecosystem.
Patience.
You got to get all the keywords in there, right? Got to cover all the bases. So this ecosystem will empower patients and clinicians with accurate, accessible information, allowing things like advanced analytics to support care coordination and chronic disease management, which we've heard a lot about today. What we also heard is the discussion around aligning those things or even informing value-based care with that information. So now we're going to go to the last and final one in the interest of time, and that is, we are going to drive innovation through technology.
Drive innovation through technology.
To end fraud, waste, and abuse.
To end fraud, waste, and abuse.
So many of today's panelists have highlighted the importance of fraud, waste, and abuse, and they've challenged us to think about it from a different perspective, thinking about it from the perspective of patient safety and how it impacts lives, not simply how much it costs, billions of dollars to American taxpayers. And so leveraging digital tools and digital decision support within EMRs and other tools to enable patients to have the opportunity to report on fraud and waste and abuse directly will give us the tools that we need to better identify low value, fraudulent, harmful, early detection. We want to get it sooner rather than later. And so those are the 3 pieces that I'd like to recap today, and I will now turn it over to Will Harris.
Will Harris, also Deputy Director for CCSQ.
Thanks, everybody. And thank you all for being here with us today and for getting this conference started off to such an amazing and strong start. I had the real privilege today to hear about a few different topics that we highlighted here at the Quality Conference that really drove home for me the motivation that each of you and all of our speakers have for why we got into this business of healthcare policy in the first place, why we're driven to do it, and why we're here at an event like this today. So I first heard about the launch of the 13th scope of work for the quality improvement organizations, the QIOs, and the amazing work that they're doing. That launch happened very recently, and we got to hear about its progress and what its focus is going to be for the next few years. I then heard about the really exciting progress that's happened for the acute hospital care at home program, which has been a really innovative and groundbreaking new field that we've seen explode since the COVID pandemic, the beginning of the COVID pandemic. And the lessons that we've learned through that process, through caring for those patients at a more comfortable setting for them, has been really beneficial to everyone involved. I finally split a little bit of time between hearing about addressing problems with ED boarding across the country, as well as improving nutrition and addressing malnutrition in nursing homes. And through all of these sessions, what hit me from all of the speakers is the core focus, and this is going to sound really fundamental and like I'm speaking very basic to you all, but hear me out. The core focus on improving the patient experience, which is just what quality is. And getting back to that and letting that drive us and being our North Star is what tells me that each of you being here, each of the speakers talking about these important topics, have that critical part of what drives us of a servant's heart. And that servant's heart is what motivates us to do this kind of work. And being in a room full, or right now I think because of a thunderstorm about 2/3 full, being in a room that full of people with that servant's heart is only going to lead to beneficial and positive things. It's going to lead to change in the space that is going to be beneficial moving forward. And I'm really excited about it. That's what energized me today, is being around that energy and having all of you here with us today. So thank you for being here, and we look forward to seeing you tomorrow morning, where I will be leading a panel of our group directors from CCSQ to talk about their motivation, to talk about their priorities for the year ahead and what they'll be focused on. So we look forward to seeing you then. I'll turn it back to Dora.
Thank you, Will. We are, again, just thank you so much. And so we also want to hear from you. What was your takeaway? What was your favorite session, your favorite speaker? Was there any tidbit that you'll be taking back with you that will change how you do your work? Share your thoughts on social media using hashtag QualCon25. We really want to keep the conversation going and amplify the incredible work that many of us were able to hear about today. And so this is officially a wrap for day one. We hope you'll bring your energy and excitement with you for day two tomorrow. We have even more thought-provoking plenaries, the breakout sessions, the tracks. It's going to be just as amazing tomorrow as it was today. And so in wrap, thank you for your passion, your presence, and your partnership, and I hope you have a good evening. Thank you.